Hi, today we're going to talk about the interaction of the family in the situation when there's a child with developmental disabilities and how to best prepare you as a healthcare provider to interact and provide care to the best of your ability. Some of the objectives for this lecture: we are going to look at the impact of developmental disability on family functioning, talk about assessing and intervening with strategies and resources for families, talk about the importance of the principles of family-centered care when providing health care to families with a child with a developmental disability, and the influence of societal attitudes and the different sections of society on people with disabilities and its impact on the family. To talk about the family, we really need to examine family systems theory and realize that the family exists within a broader network of communities and social networks, that families possess strengths and resiliencies for guiding their own life course and how they deal with the child rearing issues. And that includes child rearing issues of typically developmentally children and those with disabilities. And realizing that all families deal with this regardless of the type and degree of their child's disability. It's almost like a normal developmental milestone of a family. We want to consider Bronfenbrenner's ecological systems model in looking at the different natures of families' existence and the systems that they interact with. And that wants to we consider it families as being interactive, interdependent, and reactive. And acknowledging that they're very dynamic. Their resiliency and their strengths and their weaknesses are a very dynamic state, so there's a lot of changes to be expected. Also in the family system, we need to consider that their traditions, their values, their ethnic heritage, and their spiritual beliefs all impact the family dynamics and how they will best care for a child with a developmental disability. And that just gives you an idea of Bronfenbrenner's ecological systems model. Again, looking at the microsystem that includes the home with the child and the adults, parents, and also looking at all the different realms that the child will interact in, as far as home, perhaps religious settings, neighborhoods, and school when the child becomes old enough to attend school. Looking at the mesosystem surrounding that, where the home, the school, the neighborhood, and the religious setting is a larger focus, not the microcosm of looking at it from the child's point of view or the parent's point of view, but in the larger realm. Looking at the exosystem, so how that they'll interact with the school board when they have to advocate for their child for services, local government's input on it, how the parent's workplace may interact when the parent has to ask for additional time off or make accommodations during child caring for a child with a disability. Looking at how media represents and treats people with disabilities, and again, local industry with accommodations, especially when we're talking about the transition period into young adulthood, which we'll focus a lot more on our last class. And the largest system they would interact with would be the macro system, and that looks at our belief in ideologies on dealing with disabilities in our culture. Families vary on how they cope with the diagnosis. The responses differ widely, and they can depend on a lot of different things. The severity of the child's disability, and again, it's the family or the parent's perception on the severity of the disability. They may see things through their eyes much differently than we do with healthcare providers. So that's something to take into effect too. How prepared they are. Some families go into the delivery and birth situation knowing and having the expectations met prior from genetic testing, ultrasounds, other types of testing, so they understand that there is potentially a significant illness or condition for their child before they go in. Some families are totally unprepared by their choice. Perhaps they didn't want to know, or by the fact that this was just an unanticipated outcome of what they presume to be a typically progressing pregnancy. Having prior knowledge of the disability and beliefs of why the child may have it, most parents will blame themselves, and even parents that are knowledgeable on medical conditions still have an inherent feeling of, maybe I missed that one prenatal vitamin, maybe that would have made a difference. So again, assessing that and considering the feelings that they may have. Whether or not they've had experience interacting with an individual with a similar disability. Perhaps they even have another child at home with this disability. So again, their prior experience makes a big difference on how they'll cope potentially with the diagnosis. Many families will remember the impact of that moment when the healthcare provider gave them the news about their child and the diagnosis and potentially the prognosis of the child's condition. So really focusing on who's the best person to deliver the news and realizing that that is a learned skill. It's not something we're born innately is to be able to give bad news to families or any patient per se, but realizing that that may be something that you could be mentored in, and certainly the first times it comes up in your practice independently or while you're learning, that you would watch and listen and really think about the positive ways, and take those with you to use in your roles, but also think of the potential for improvement on some of the communication skills. And we focused a lot on communication our first day. Other factors that can influence the response on how families cope with the diagnosis is the timing, the words used, the emotional support that professionals provide, and again, arm yourself with your best support systems when you're going in and giving bad news and when you're supporting a family through it. And you may have peers or colleagues that have done it numerous times, are very knowledgeable on the resources. They may even have a child with a disability themselves. So consider any support that you may need to give the news to a family. Other factors would include the beliefs about individuals with disabilities, their knowledge of the treatments that may be expected, the family's receptiveness in accepting help from not only us as healthcare providers, but their friends and perhaps other family members. And when you realize, too, don't forget that you may have to really pay attention to the appropriate terms you use when speaking to families so that they have a clear understanding that we're not using a lot of medical jargon. And again, knowing that the one thing that the family wants to cling to, regardless of the extent of the disability, is that some type of hope, be it not for hope for their child's typical development, but perhaps hope that you will be compassionate in caring for their child. Things to consider as far as the parental response is that it is unique and it's personal. It may be culturally driven. There's also a lot of distress involved for them initially, and then they may be in shock. There may be some denial, refusing to believe what you're telling them. Again, we mentioned guilt before as a normal expectation in the response. They will have an overwhelming sense of loss because even though they will love this child perhaps and accept them and delight in their achievements, they have lost the birth of a typical child in the presumed outcomes of a pregnancy. So that loss never goes away. So really keep that in mind. And a lot of what we learned when we listened to the video, Welcome to Holland, okay, that is the loss that the family will always be aware of. There's a lot of other different stressors, okay, intellectual stresses and instrumental stresses. And realizing that the family, even if they are medical professionals or healthcare professionals, they may function in a completely different specialty, so they may not be familiar with everything that you're telling them, especially because this wasn't the time that they were expecting perhaps to hear all this. So they have to integrate a lot of information about the physiology, the expectations for timing and type of treatments, the rationale or reasoning for the treatment approaches, and perhaps adverse effects on the managements that you're asking them to think about and sometimes make a very timely decision immediately on how they want to manage the care of their child, and some being forced with the decision of whether or not they are going to have medical interventions or they're going to decide for more palliative care. So again, a lot of information having to be absorbed rather quickly. Other stresses that we call instrumental stresses would be things like dealing with the financing, especially if we're looking at a prolonged hospitalization. There may be a loss of income for the parents. Dealing with insurance policies. We all know how stressful that can be. Managing a division of labor in the family as far as providing for the child with special needs while accomplishing other family responsibilities that can include bringing home the money, also care for another child, maintenance care on their homes, other responsibilities of individual and families. So again, a huge stressor for them to try to manage all of this. Other stressors to include in this would be emotional stressors, really having to deal with the uncertainty of the diagnosis and the prognosis for the child, and we may not have any answers for them for quite some time, if not years. Realizing that there may be some very outward, visible signs and symptoms of the disability, severe behavioral problems being a concern, that can put the parents at risk for post-traumatic stress disorder. Other things that can make a difference with the family's coping of the diagnosis is the use of the family-centered care approach, and that's what we are hoping that this knowledge will assist you in using when you start into your practices. But partnering with families by providing them with education about the condition, making them more aware of resources and what's available for them and their child, and helping them examine the different treatment choices with the understanding of there may be benefits and there may be less advantageous effects of each of the individual treatments that we're asking them to consider. Assess for and be ready to intervene for parental depression. They're at increased risk, families with a child with disabilities. Things that may make it worse is the emotional stress involved with physical strain, physical exhaustion of care responsibilities. The moms or the women are at more risk for this because of that caretaking role. Frequently if one of the parents has to stop employment to take care of the child at home, it frequently is the mother. They're more at risk for depression, and remember that this may be portrayed more as an anger response in this situation. So just be careful as far as assessing for depression and keeping that in the back of your mind. Remember that there may be cognitive and behavioral therapy and interpersonal therapy that may be helpful for the family, if not during the initial time of stress of diagnosis, but ongoing, so they can maintain the best relationship not only with the child, but the spousal relationship and the relationship with any other children in the family. Some of the long-term effects that we need to think about as far as the long-term care for the child with disabilities is the family coping. And the good thing is most families are resilient and at their own pace do learn to cope with this stressor. We need to be positive in recognizing and applauding them for their positive outcomes, and realizing that it can cause increased cohesion in the family, which is a good thing. And generally the family members become much more compassionate towards each other and much more compassionate for people outside the family that they know with disabilities. Really thinking about parenting networks as often powerful supports, which you're becoming more exposed to through the class and some of your other clinical experiences. Really thinking about hooking them up early when possible. Anticipating, though, some families may not be ready for parenting networks, that they may have to wait for a little while until they're ready to go out and see and interact with families of children with similar or other disabilities. Other things to consider when we're implementing family networks, parenting networks as a resource. If they're having get-togethers with the children, please realize the family then may be interacting with children at higher levels and lower levels of a similar disability. So that may make them saddened to know that their child is more significantly ill. Also, as some of the children are transitioning and the older children, a family may become more aware of what are expectations that are perhaps more realistic but disappointing to them when they're interacting with older children in a parenting network type of social activity. So other services that can benefit the family when delivered in a family-centered manner, and realizing that we need to address their identified prioritizations and not particularly ours, really realizing that their priorities may be very, very different for many, many different reasons than what we think about it, and they may change over time. We must assess the family strengths and their needs for the level of assistance at that time and realize that that can vary from day to day, from month to month. It also may vary on the normal developmental tasks of the family as far as active child rearing, as the kids may become more independent, and eventually as the children, either be it the child with a disability and or other siblings, leave home, and the parents become at a mature age and think about retirement and realize that the resources may change too accordingly. Some of the things that we can be helpful in interventions with the families is thinking about intervening for strategies for coping. Two of the common techniques we use are reframing and normalizing. And when we reframe, we reinterpret a behavior or its context by viewing it from a different lens frame, ours obviously as a healthcare provider, and focusing on the adaptive and positive aspects. So if a parent is recognizing a symptom and is very stressed about this, reframing it as, remember we talked about the physiology behind this and some of the symptoms that you might see, and you did a great job by assessing it, and we expected that this may happen, and this is our plan for dealing with this. Okay, so again, reframing it as you assessed it, you did a great job, and remember, we were expecting that this could happen. When we talk about normalizing, we talk about communicating that the emotions and the struggles that they're experiencing are both normal and expected, and that's not making trite of it or disregarding it, but just letting them know that most families in their situation go through with this type of stressor, go through those feelings, and that the feelings of being angry and denying and blaming and guilt, and that they're normal, and that we expect that they may go through those different feelings at different times, and that's okay to feel that way. We realize that the siblings in a family are also significantly impacted when there is a child with a disability. And this may be something to talk about with the families as far as they have a sibling currently at home or their potential plans for siblings after having a child with a disability. So certainly how they can, what expectations they can have in responses. Siblings have unique concerns, and it can vary with the gender, the age. When we talk about age significantly, we're looking at the developmental level of the child, okay, the birth order, and the overall temperament of the child, of the sibling, and the child with the developmental disability. Things that we want to consider is that baseline, siblings generally have mixed feelings about having a sibling, okay, and someday, just like any other typical sibling relationship, sometimes it's great to have a sibling and sometimes you'd rather be an only child. So realize that they may have mixed feelings, and it may vary just as it would normally. The other thing to consider about siblings is what their expectations were. Sometimes we encourage families who have perhaps a very strong history of genetic disorders or have found out early via ultrasound that there is a disability for the child, be it developmental or a significant medical disability, that in age-appropriate terms, developmentally appropriate terms, they may want to start preparing the sibling for what will be the outcome or expected outcome, realizing that the sibling may have very different expectations with the birth, and even though we think they're understanding, they may think they're getting a brother or sister at the same age, the same size, and the same developmental expectations that they are. So getting someone to play with right then, right there. They may have totally different understanding of what they're getting. A great story that I like to tell people is, even though we tried to prepare my oldest son for the birth of his brother, when he met his brother for the first time, his first reaction was, I thought I was getting a horse. So again, even when we try to prepare, we really have to get a handle of what the sibling was expecting and how far from the expectation did we deliver as far as a child. So assessing the level of understanding is really important. Really be honest with the parents and let them know that overall, a lot of siblings do very, very well with the adjustment, and many choose to enter helping professions. They become very, very compassionate, not only towards their sibling, but outwardly to other people with disabilities. So there can be some positive effects of what can be a very difficult transition period. We do know that siblings fare best, have the best outcomes when the parents' relationship is stable. And that includes a stable relationship with the child with a disability, with the child that doesn't have the disability, the sibling, and with each other. And when we're talking about a stable relationship, that doesn't necessarily mean that the family is a cohesive unit at that time. Okay, so they may not be married, they may be separated, they may divorce, they may have never married, but as long as their relationship is one of caring and mutual caring for the child, being it stable, it can have a very positive effect on the coping for the sibling. That feelings are discussed openly, that they acknowledge when the sibling child is angry or resentful or feels neglected. Those are normal feelings, and we should talk about them. We explain the disability completely, so accentuating what the child with a disability can do with them as far as how they can play with them or interact with them, but having a good understanding of what they may have limitations in doing. Being very careful as the sibling child gets older to remind the parents that it's not the role of the sibling child to care for the child with a disability. And we're not talking as far as contributing, helping pick up something that dropped or, pushing their sibling when they're in the park if they're in a wheelchair or things like that. But we're talking about long-term chronic care responsibilities, that we don't want the sibling child to lose their normal childhood of typical childhood experiences for providing care for their sibling with a disability. And again, sometimes parents do that out of necessity, not with any malicious intent, but we really want to encourage them to consider other options if available. Effects on the extended family should be considered, specifically grandparents. And grandparents can harbor a lot of guilt about a child with a disability, knowing that ultimately grandparents are parents too, and they really want what's best for their children. So the child with a disability's parents, they can assign blame on themselves, blame on their child. Frequently the target is blame on the child's other parent that's not their child. So, no, our family's never had any genetic disorder, it must come from their side. Things like that. They may be rejecting of the child, and know that sometimes it's fear or lack of knowledge. A lot of times with the grandparents, please remember that in the age that they were child rearing, okay, or that they were being reared as children, children with disabilities frequently were institutionalized. They weren't cared for at home. So there was a different view of society of that time on what was acceptable care of children with disabilities. So consider that too. The quality of the relationship the grandparents have with their own children does affect their acceptance of the grandchild's disability. So if there was a strain in the relationship before, there may still be one, or it may be worse. Excuse me for a minute. Some grandparents may experience denial more strongly than the parents do. Again, it's a different type of relationship, different type of feelings about the birth of that child. Grandparents can also be an amazing sense of support, providing respite care, help with chores, house maintenance, things like that, and potentially financial assistance. A great example I like to share is that when my youngest was born, he had a prolonged NICU stay and had to go home on apnea and bradycardia monitor. So unfortunately, the spot that we had reserved for him in the child care center that his sibling went to, he could not take for 6 months. They were nice enough to hold it for us though, because of his monitor. So he had to be cared for at home with my parents while I was at work or I was in my doctoral program at that point. And to do that, to care for him, they had to go to childcare classes, and my father proudly showed his friends his CPR card because he had to go to CPR class. to learn how to do infant and child CPR. So again, they can have incredible resilience and can be such a significant source of support for the child with a disability and the entire family. And realize that extended family can also help or hinder the parent's ability to cope, and really assessing and getting their take on who are their best support. It may not be close family that we would expect. It may be extended family. It may be cousins or second cousins, things like that. So again, keeping an open mind as to who the family views as support. Other things to consider as far as the effect of the child on the child themselves with a disability, thinking about what are the normal developmental expectations. When they're in preschool age, they might not recognize that they're any different. Do we point that out? Not necessarily. They will become more accustomed to that later, and a lot of it has to do with how the family has dealt with that disability. Play serves as an early learning experience as far as expectations and watching other children. So even encouraging play dates with children, other typically developmental children that are open-minded and can handle without any problems playing with a child with disability. And please know that the things that the children focus on may be very different than us. A lot of time kids don't notice. They may, if we just tell them, oh, Johnny doesn't walk, he has a problem with his legs, they don't work as well, he gets around in this chair. A lot of times the kids are fine with that, adapt that, and incorporate the chair into their play. So really having an open mind and watching and facilitating play for preschool children with disabilities. Individualized service plans, setting the children up as soon as we can with early intervention services, and once they enter the school district, individual education programs, or we call them individualized education plans, for their accommodation with their disability. And we'll talk at length about that on one of our classes, later classes, and I'll give you examples so you can see what one of those looks like, what the documentation may be, and how you may be expected to provide medical documentation as the school district tries to accommodate the disability. Once they reach school age, most children are aware of their abilities and challenges. They may need help in dealing with those feelings of being different. Generally, if the family has been acceptance and they've participated in family activities and the family's encouraged participation, they have a better feeling about themselves with the disability. Hopefully we can include them in as many opportunities of normal childhood experiences with adaptations or assistance. And certainly there are services like OT and PT that can help us do that. Consider programs like Special Olympics and camps for children who have varied abilities for a lot of reasons. So they become more inclusive with children of their own age and participation. If there are specialized camps that are stay-over camps, also may provide fantastic respite for a family that could really appreciate it. Programs like Special Olympics, though, are very helpful because of the mindset of the Special Olympics. Every child's clapped for, every child is recognized, and they may have a sense of achievement too as they compete against like peers with disabilities. Effects on the child with a disability in adolescence, we have to realize that they may be becoming aware of their barriers for independence and really being concerned if they're going to be self-sufficient in it and trying to make mature decisions. Okay, they're going to desire for peer approval in the areas that all adolescents judge: intellectual, physical, and realize that their views may need to be adjusted because of the limitations of their developmental disability. So things like, driving a car, going out independently without assistance or supervision, things like that. So giving them realistic expectations and paying attention to safety. We know that differences are less of an issue for adolescents with disabilities if they have at least one supportive friend. We're not talking 5, 10, 12 friends. That would be great, but at least they have one supportive friend, and really encouraging that peer relationship and all the obligations and responsibilities that they have as a friend, but all the benefits of their friend. A peer group with diverse members, realizing that everyone has individual differences, things that we're proud of ourselves and things that we would like to change if we could, but realizing that no one is perfect. So peer group with diverse expectations. Parents who encourage participation in activities. So again, parents that have encouraged the child to try new things with varying levels of success. We know that's helpful for an adolescent with a disability. And realize that they will be accepted being different, maybe not by everyone, but by most people. Realizing that there are some of the normal developmental stages that all adolescents go through, that it can be amplified with a child with a disability. So mood and behavior swings, the fact that they are going to be excluded from some activities, and that's something that, no, it's not fair, but we do have to pay attention to that, mainly for the safety and the achievement of the child. They may also have a lack of independence, which all adolescents strive for, but certainly recognizing this, acknowledging it, but also giving them as much independence as can be possible. Into young adulthood, realizing that although some adolescents with disabilities do achieve independence, many may struggle and may not attain that goal or an altered level. And this can be hard, not knowing from childhood what will be the expectations in going into adulthood. Considering with the family, for young adults who may not achieve true independence, there are other alternatives available. And we want to encourage them to consider these very, very early. Because unfortunately, a lot of the alternatives may have waiting lists. I've heard of waiting lists up to 3 to 5 years for group homes. So again, getting them involved early is considering what options may be available, and to do that pre-planning. Things that they may want to consider is sheltered apartments where they may have a roommate with a disability, but they're checked on daily with very regimented mastery of household skills as far as cleaning and cooking and balancing a checkbook, and in sheltered work environments. And 2 group homes where they may live in a group home with disability children. And again, some of the things that we have to focus on too is care for that young adult with a disability as the parents age, and who will be the guardians, who will manage the legal issues, things like that for that child. The ability to cope and become independent can possibly be facilitated by the degree of the disability, or less so, and the effectiveness of the family to plan and manage that transition, both emotionally and financially. And lastly, talking about some principles of family-centered care as you provide health care for families with a child with a disability and the different roles. We want a collaborative relationship based on mutual respect with open communication. I may disagree with what a family says or choices they make, but I'm respectful, knowing that they are making the best decision they can, hopefully for the best decision for the child and their care in mind. And there needs to be open communication going both ways, from me to the family and from the family to me, so I can provide the best care I can. Professionals need to be flexible and responsive in coordinating the efforts with the family and with other professionals that we get referring services in. Things don't always go when planned with a child with a disability, and there may be many setbacks, and families wax and wane with their ability to provide the most optimal support with all the stressors they have going on. So realize that we have to be forgiving and flexible with them. We do know now that there's a greater appreciation for people with disabilities in society and with healthcare providers, as evidence of providers like yourself being willing to take courses like this. There's more educational, vocational, and housing and support services available, so trying to be informed of those in our community so we can be knowledgeable on the resources that we can assist a family with. And realizing and being advocates for federal funding and protections and other laws that advocate for children and families with disabilities, so we can hopefully promote a better life for these children and their families.